So good morning, guys. I want to record a video for the session that we were supposed to have on Saturday last week, or on Friday last week. So we're just going to continue from where we ended. So like I said, for pathology, we just have to follow that's a book that I shared, not Cotran, but the pocket companion for Robin's pathology. It's very easy and straightforward. And also, we can also try to use BRS, because BRS is well summarized, and it's just on point. It just tells you the things that you're supposed to know. So I like BRS, and at this point in time, I think we can also put the pocket companion to Robbins into consideration, because it's also recommended to use that as well. Yeah. All right. So like I said, we're supposed to follow this book or the other book, but the other book is it's quite complex. I can still use that same very book. I like it. And if you want to answer those questions again, you need to go back to the basics that we discussed. That book for, I think it should be Dr. William something, that book for MCQs. Let's make sure that we try it. Let's go through questions every day. You answer 2 questions, 3 questions. We don't want us to be answering those questions 2 days before the exams. That is why you forget. So we don't want that. We want to start doing that now. So now, I don't know if people will be able to see the slide, but as you can see, this is central nervous system pathology, BRS. So congenital disorders of what's this? Let me just check what's this. I wanted the video to assist. Okay. All right. So now, kasana kupfina video Geoffrey. Kasana kupfina video na mwana hizi. Fina video nchina video kapin. Nikate wini. Debo ngwangu nchi. Hey. All right. So, so the group of disorders is characterized by failure of closure of the neural tube. So we know the neural tube from the embryology from the embryology of basics. So from the embryology basics, we know that we have that, you know, what do you call that? You have what you call the 3 layers of okay. So you have what you call the 3 germ layers. You have got the topmost one. You have the one that is the middle one. Then you have the one that is so I like something. Then you have the downmost one, the downmost one, this one. So now there are 3 germ layers that we know. The top one, the topmost one is called the ectoderm. The second one is called the mesoderm. Then the third one is called the endoderm. So now if we talk about the ectoderm, there's that neurulation that we talked about. Neurulation is just the formation of the neural tube. So there's a fold that is formed like that. There's that formation of your neural plate. From there, you're going to develop what you call the neural folds until you form what you call the neural tube. So when that neural tube is formed, what happens is that it's supposed to be closed. There have to be that closure of that neural tube. So now if that closure does not happen, if that closure of the neural tube does not happen, you're going to have different regions or congenital deformities. And those congenital deformities are called the congenital deformities that are arising from the neural tube are called the neural tube defects. So there are a bunch of them that we have to know. So, so from my diagram there, I think we are from my PowerPoint or from my slide. These disorders are characterized associated with increased consumption of alpha-fetoprotein in amniotic fluid or maternal serum. So how do you know that the patient can have this, neurotube defects? So when they come to the hospital, then you do the serum, meaning the blood, you do the test of alpha-fetoprotein in amniotic fluid or in the maternal serum in the blood of the mother. You just do the test for the alpha-fetoprotein. You'll find that it will be highly elevated or it will be increased. So that will give you a link, or it will give you an hint of what is happening, or what is going on in the mother there, in the fetus. So you know when they bring nurses, when they give you a scenario question, and then they'll tell you that the patient came to the hospital and then after doing the test for the alpha-fetal test, it was realized that it was highly elevated than the normal. What do you think could be a congenital defect that would be going on in the mother or in the fetus? Sorry. So tell them it's a neurotube defect. But what type of neurotube defect specifically? Because it's more like a spectrum of conditions. It's a lot of them. So you have got spina bifida, which is that's the failure of the posterior vertebral arches to cross. Spina bifida occata, spina bifida with no clinically apparent abnormalities. So at least the spina bifida posterior vertebral arches, they fail to cross. I think that's what is significant there. But if you talk about the spina bifida occata, if you check through the diagram, there's something like that. There's tuma hair, there's that small bulging, etc., etc. So spinal bifida with no clinically apparent abnormalities. When they say occult, it's more like how can I, something that is very small, in short, very small, and not really complex, but very small. That's occult. That's what it means when they say spinal bifida occult. So you can have what you call spinal bifida occult, which can be asymptomatic, meaning that you cannot see. When they say asymptomatic bone, meaning that it's not something that is visible, but it's just very small. That is for spinal bifida occata. But for spinal bifida, the original spinal bifida, you'll be able to see the features from the baby. The baby is having that, the unclosed posterior vertebrae arches. But for spinal bifida occata, you cannot see anything. You may or not see something. That is called spinal bifida occata. So just see a few things, a few features there. So this one, the spinal bifida occata, can be severe or mild. If it's mild, it's called spinal bifida occata. Or severe, if it is severe, it is characterized by disorganized cord segment, meaning the umbilical cord, you can even be seeing it outside, which is more like an outpouching. It shows like an outpouching, very, very outside. That's what you call the spinal bifida. In short, in layman's terms, we have spinal bifida. Spinal bifida we know is failure of whatever. Now, that failure of closure of the posterior vertebrae arches is divided into severe or mild. So mild, you have got spinal bifida occata, and then the severe one is the one that we just say, it's one that we call spinal bifida in general. Spinal bifida cystica, spinal bifida complicated by injection of meninges through a defect. So now you have that spinal bifida now. Now that spinal bifida, you have now the meninges. We know the meninges, they are injecting through the same uncrossed area. We know that there is that uncrossed area because those posterior vertebral arches didn't cross. So now what is happening is that in the same uncrossed or in the opening that remained, the meninges inject through there. Okay, that is called spinal bifida cystica. It's more like a cyst. Meningocele. So what is meningocele? Simple and straightforward. Meninges, injected membranes consisting of meninges only. That is called meningocele. So now, any membrane that has injected, regardless of its type, for as long as it's a membrane that has injected and it only consists of meninges, it only comprises meninges, nothing Nothing apart from the meninges. There's just meninges that are injected through that. That is called meningocele. Guys, these are the questions that they will bring. They'll ask you, they'll tell you, okay, the patient came to the hospital, what, and then it turned out that the patient had a posterior defect, which was characterized by the membranes consisting of meninges only. What is your likely diagnosis? So you tell them it's meningocele. That's D. E, meningomyelocele. Meningomyelocele. So remember we talked about this. I even told you something. I talked about this, but I talked about meningomyelitis, which was more like the central damage of the spinal cord, which specifically affects the versus the anterior not spinothalamic tract. Let me just say anterior tracts and not the posterior tracts. That is meningomyelitis, but this one is meningomyelocele. So since we have meningo, meaning that we've got meninges, myelocele, something to do with fluid, something like that. So portion of the spinal cord included in injected tissue. So now in short, the difference between meningocele and meningomyelocele is that meningocele only comprises meninges, while meningomyelocele has got meninges and part of the spinal cord in the injected tissue. When we say injected, meaning that it is more like it's forming an outpouching in an abnormal opening. Yeah. So what is myelomeningocele? Myelomeningocele represents the central nervous system outpouching through a vertebral column defect. Most occur in the lumbosacral region associated with lower extremity motor and sensory deficits and disturbed bowel and bladder control. Because this meningomyelocele it's more like affecting what's this? It's more like affecting the spinal cord, especially they're saying the lumbosacral part of the spinal cord, meaning that all the tracts that pass through there are going to be damaged unless the patient who have what is or have deformities or lesions in the tracts that are passing through the lumbar sacral part of the spinal cord. That is very simple. Then you have some other things that they haven't put there. Let me just highlight them and put them there. Let me put them here so that people can look up to them. You have what you call, let me just capitalize, okay. You have what you call encephalocele. I'll define them. Sorry, just a minute. I think encephalocele is the encephalocele is there, spinal bifida. Okay, that's the one that was just missed. Everything is just there. So what is encephalocele? Encephalocele is a malformity central nervous system diverticulum extending through a defect in the cranium, typically in the occipity or posterior fossa. So encephalocele or encephalocele, this is a diverticulum that is malformed, meaning it's congenital, malformed diverticulum. Diverticulum is more like an outpouching. It's more like just a sac, something that is just enyecting. But this happens inside the cranium, specifically maybe the posterior salaba colucobo, which is going to be colucobo, or it will be anterior of that's no, let me just say it will be maybe in the occipital or the posterior fossa. That is why it is usually found. That is called encephalocele. So we've talked about spinal bifida, which can be a symptomatic bone defect, spinal bifida or kata, or severe malformation with flattened or disorganized cord segment with overlying meningeal outpouching. So spinal bifida, we know that. Spinal bifida or kata, we know that. Spinal bifida cystica, we know that. Meningomyelocele, I've already explained that. I've told you that it's common in the lumbosacral region of the spinal cord. And we're saying that there are meninges that are injected as well as part of the spinal cord. How about encephaly? So encephaly is a malformation of the anterior neural tube. Anterior neural tube resulting in failure or development of the cerebellum. In short, the patient or the baby will be born with what? The baby will born without let's use the word fetus. So the fetus was born without the brain. The fetus was born without the brain, that is known as encephaly. So they will have a very small head, a very small frontal forehead. We can just say forehead because that's what the brain is. So the baby will have no brain. So there will be absence of the fetal brain in ancephaly. Guys, these are the most questions that are asked. They can ask you to define them. They can ask you to explain them just through. Maybe in MCQ they can bring these what's this? They can bring what's this? They can bring these MCQ. They can bring scenarios there. So also have what the one that is not put there is called the holoprosencephaly, 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 encephaly, encephaly, encephaly. So holoprosencephaly is also a forebrain anomaly. It's characterized by an incomplete separation of the cerebral hemispheres. Now imagine those hemispheres are not separated. They might be separated, but they just, maybe a deformity somewhere. They're not completely separated. They're supposed to be separated. And you remember what we said when we were discussing anatomy? We said we have got what we call those corpus callosum, which are more like commissures. We talked about commissures. We talked about those fibers that I've forgotten their names. I've forgotten their names, but we have to remember that we have such kind of things happening. So now in the holoprosencephaly, what happens is that there'll be incomplete demarcation between the two hemispheres, meaning that the hemispheres that are supposed to be separated and connected by the commissures, such as the corpus callosum, they are not separated anymore. They are not separated completely. That is important, guys. That is very important. So it is also associated with midline facial abnormalities. Holoprosencephaly can result from mutations of whatever. But what is important is to remember that there was incomplete separation of the brain structures. So we define syringomelia somewhere. Where is that syringomelia? So they didn't put syringomelia there, right? Just talked about meningomyosine. So what of syringomelia? Because I talked about it. It's also a congenital anomaly. Syringomelia. Syringomalia. Syringomelia. Syringomelia, I talked about it, guys. If you remember very well, I did talk about this. Syringomelia, and this one I didn't talk about it. Hydromelia. These are the things they'll ask you guys. Hydromelia. So what is encephalocele? We've talked about it. We've defined encephalocele. I defined I've already described what encephalocele is. Holoprosencephaly is, I've already explained that. I said holoprosencephaly is characterized by an incomplete separation of cerebral hemispheres when they are not separated. That is holoprosencephaly. How about encephaly? I've already talked about it. So people can just look up to them. Encephaly, I said, is what? It's a malformed CNS, meaning central nervous system, the reticulum, extending through a defect in the cranium. Typically in the occipital or posterior fossa. That's where that pouching is going to be in encephaly. So that is important to remember. Syringomelia is what I'm trying to explain. So what I'm about to explain now. So what is syringomelia? Anyways, what is syringomelia? Syringomelia is simple and straightforward. Syringomelia is just the formation of a cleft-like cavity in the spinal cord. So this can be acquired or it can be congenital. So for example, if you have, let me just draw. so that people can be getting the gist of what I'm talking about. We're just assuming here, guys, if this is our spinal cord, you know how the spinal cord is. So you know you've got that thingy that is that side, then you've got the other thing that is this side. So now if you've got the central canal here, we're saying that the formation of a cleft-like, meaning the wall, like in the central part of the spinal cord, that is called syringomelia. How about hydromelia? It's just hydro means water or fluid, so there will be accumulation of fluid in the central canal. It will be a lot of fluid and it can even expand. So these are expansions of the central canal. Very simple and straightforward. So that is very important. The other thing that they haven't put there is cerebral pause. Cerebral pause. But they don't ask questions on this one. That is why I just want us to be very straightforward of the things that we're doing. Cerebral pause, I think we are very familiar with this, but it's a broad term for non-progressive motor deficits related to pre and perinatal neurological insults, meaning that the patient is the baby or the fetus will born with this condition, when they say pre or perinatal neurological insults. So prematurity is the major risk factor, meaning that there's that premature of the baby. The baby has to mature, maybe because the mother delivered at a very tender age or before term. Maybe the mother delivered the baby before 32 weeks. That is called premature. Before the baby matures, because for the baby to be fully mature, it has to reach 32 weeks. That is called the fetal age of viability. So now, if the baby is born before 28 weeks, when the baby is born before 28 weeks, it's going to have congenital malformations, because by that time a lot of organs haven't fully developed. So that is what causes most of the cerebral palsy. It's just prematurity. So basically, that is what cerebral palsy is. But we know the presentation. So depending on the location of the injury, lesions are clinically manifested by dystonia, spasticity, ataxia, atetosis, or paralysis. So dystonia is more like just having difficulties in the movement of the extremities. I think you've seen those people that when they're walking, the way they walk, the ones that have cerebral palsy. That is called dystonia. They'll be having difficulties moving their extremities, the limbs, etc., etc. Spasticity, meaning like there's spasm. I don't know how to explain that. I can only explain it very well if I'm with you guys. So that is what you need to remember there. Then there's also Chiari malformation. Chiari malformation. So let's remember cerebral palsy. So this same cerebral palsy is divided into other parts, or into it is divided into the causes and the types, but that is not important at this age or at this stage. Sorry. So we also have what you call the Dan-Walker malformation, Chiari malformation. So now let me just write them down and explain something up on them, just in case you see some MCQs. Dan-Walker malformation. How this thing is okay. So Dan-Walker malformation. You have the second one, Chiari. These things you just have to master them like this. Chiari malformation. And there's Chiari type 1 and type 2 malformations. So there's this one it's blanched into two. You have type 1, then you have Chiari type 2. So let's start with Dan-Walker malformation. So Dan-Walker malformation is characterized by an enlarged posterior fossa. Posterior fossa of the bases of the brain. You've got the posterior fossa, you've got the middle fossa, and the anterior fossa, and I talked about this. So now, when there is an enlarged posterior fossa and there is no cerebellar vermis. So the cerebellum itself is divided in two parts. So now if the cerebellar part is not there, and there is a large midline cyst with brainstem nuclei dysplasias, meaning that the brainstem nuclei that are there, they are not really in the conformation structure that they're supposed to be in, but they are more like just dysplastic, they are disorganized there. So how do you diagnose Dan Walker malformation, guys? These are the MCQs, the scenarios they bring in MCQs. So number one is that there's an enlarged posterior fossa, meaning the posterior fossa is big. Two, there is no cerebella, absent cerebellar vermis. There is not a part of the cerebellum. Two or three, sorry, there's a large midline cyst. Midline cyst is large. There's a cyst. A cyst is just, you know, the cyst, what a cyst is, a sac. That is not even normal, it's abnormal. So there's a midline cyst there in the brainstem. But again, the nuclei in the brainstem were just disorganized or dysplastic. Guys, that is how they are going to ask you, or that's how they are going to bring what's this, a scenario. They will be like, no, the patient came presented with whatever, but we don't know how the patient presents. We don't know how the patient presents in this case, but they will tell us the clinical features. Oh, the patient was found to have an enlarged posterior fossa with an absent cerebellar vermis and large midline cyst. In your head, you need to think of Dan Walker malformation. If you want to prove me, to prove what I'm saying, you need to go to that slide, that MCQ questions, the one that I sent to you guys. You'll find whatever that I'm talking about. And then we've got anodicary in 1 and anodicary type 2. So in anodicary type 1, this malformation is associated with low-lying cerebellar tonsils extending into the vertebral canal. It is often clinically silent, but it can present with CSF flow obstruction. Imagine the cerebellum, which is not supposed to end inside the skull, it even extends into the spinal cord, vertebral spinal cord. That is called Chiari malformation type 1. In the sense that this is often silent, meaning it's not like it will be just full or generally silent. There can be some symptomatology out there. There can be some clinical features. But this can also present with CSF flow. So if they bring a scenario and they tell you this patient presented with what? The cerebellum, which was located in the vertebral column, and he had signs of increased intracranial pressure due to obstruction of CSF flow. Think of anodicary malformation type 1. How about type 2? So anodicary malformation type 2 consists of a small posterior fossa, a small one. Remember Dan Walker, a big one, an enlarged one. A small posterior fossa, a malformed midline cerebellum. Remember, the cerebellum is there in the posterior whatever. So it will be malformed. It won't be very normal. With the extension of the vermis through the foramen magnum. So now that vermis of the cerebellum, it passes through the foramen magnum. Guys, they never told me this. But I'm telling you guys this because I want you to know. I want you to know the specific things that they bring. If these things that I've talked about are not important, or if they were not important, I wouldn't have wasted so much of my time and talk about them. But guys, they are very, very important. They are very, very important. So I've touched almost on every malformation that we need to know. Unless otherwise, guys. Otherwise, these are the things that we need to know. So it's just to take you back. We talked about cerebral edema. I think we'll discuss it even in the PRS. So basically, this is what you're supposed to know. Don't even waste your time to go to Robbins or whatever, because I'm using Robbins, the smartest one. I'm using Robbins and BRS at the same time so that people can know things deeply. So people, let's make sure that we watch these videos. I'll make 2 videos so that 2 people can catch up with studies, even the one for tomorrow, because tomorrow we don't meet. We are meeting on Tuesday. Yeah. So next page. Ooh. So let's go to our second part. Our second part is on hydrocephalus or hydrocephalus, depending on where you come from. But as Kaputa people, we call it, we pronounce it as hydrocephalus. So, what is hydrocephalus? We've been talking about hydrocephalus almost everything. Anyways, before we even go there, let's talk about this stuff that is a torch complex. Guys, this as a medical doctor, you have to know what torch complex is. And we talked about it in microbiology last year. So what is torch complex? So torch complex is a mnemonic for something. It's an acronym for something. So torch stands for TOR, for Toxoplasma gondii, R and L. I think we members have issues with these two, LR syndrome. So R, rubella, C, cytomegalovirus, H, herpes simplex virus. So that is what torch means. Torch, Toxoplasma gondii, rubella, cytomegalovirus, herpes simplex virus, even HIV. Or you can say others like HIV, because those ones are also. So these are infections that can move from the mother and go to the fetus. These are the only infections that have been proven to move from the mother through the placenta and goes to the fetus. Very, very important to remember. So even others like syphilis, that is called congenital syphilis. That is why when the mother comes to the hospital for antenatal, we always screen them for syphilis. We do what you call the rapid diagnostic testing for Tripolima pallidum, which is the infection or the bacteria that causes syphilis. So what is hydrocephalus, guys? So, before I talk about the hydrocephalus, they're saying torch infections can lead to syndrome characterized by microencephaly, meaning that the baby is going to born with a small brain and a small head. Choroidinitis, meaning that the baby is going to have infections of the retina. Central nervous system calcification. The brain and the spinal cord will be hard to be calcified. Petechial rash. So the fetus will be born with the petechial rash. Petechial is more like what is petechial? Petechial is more like, what is petechial? Petechial is X-day to those things. So petechial is more like just to small bleeding, yeah, because of infection. So the fetus will born with infections or rash secondary to the torch infections. Hepatosplenomegaly, meaning that the fetus will born with a very big liver and the spleen, and then the baby will born with what? Thrombocytopenia, meaning low platelet levels. So this baby will be predisposed, or this fetus will be predisposed towards this head bleeding, because it will be born without a quantitative amount of platelets. So from there we go to hydrocephalus. So what is hydrocephalus? So we talked about hydrocephalus somewhere. So the flow of cerebrospinal fluid is from the main of it, or we can just assume that 75% to 95% of it is made in the lateral ventricles, and we have two lateral ventricles, the left and the right lateral ventricles, specifically in the choroid plexus of the lateral ventricles, where those ependymal cells are suspended. So those ependymal cells are the ones that are producing, putting calcium, removing the waste, putting every necessity that is important in the formation of CSF. So now when that CSF is formed, it moves from there through the intercerebral or interventricular foramen, also called the foramen of Monro, into the third ventricle. The third ventricle also adds some CSF, and it also adds some CSF. A little percentage of CSF is also produced in the third ventricle. From the third ventricle, the CSF is supposed to move to the fourth ventricle via the cerebral aqueduct of Sylvius. So from there, in the fourth ventricle, we've got two walls, or two important walls that are important. Three walls, in fact. So you have got two foramen of Rushka and the Magend at the center. So Magend at the center, then two at two at the lateral aspect. So now those holes or openings are there for absorption of CSF, or for CSF to move from where it is in the ventricles now to go into the spinal cord so that it can flow and move. But before entering the spinal cord, we need to talk about granulations. So after the fourth ventricle, we need to have what you call the granulations. So those granulations are the ones that are responsible for absorption of CSF, and they are more like connected to the blood vessels. They are more like connected to the blood vessels, the sinuses, what you call the sinuses, cerebral sinuses, sagittal sinuses, transverse sinuses. So they are more like connected. They interact with those sinuses so that there is that continuous absorption of or diffusion of CSF. That is how CSF moves, and that is the most asked question under hydrocephalus. So now, if there is maybe anything that is obstructing the movement of CSF, we are going to have what you call non-communicating communicating hydrocephalus. Or maybe everything is just okay. There's nothing that is obstructing that CSF movement. So you are going to have so that is non-communicating. No, non-communicating or communicating hydrocephalus. So for communicating hydrocephalus, what happens is that there is wait, let me just check. Yeah, there's communicating. So communicating there's between the whatever and the whatever. Okay, so now let me give you a scenario of what the question can come. So for communicating hydrocephalus, free flow of CSF between the ventricles and the subarachnoid space, meaning that CSF is just moving freely. It's just moving freely, and there's nothing that is obstructing it. But what is happening is that maybe there's overproduction, there's increased production, or maybe there's reduced absorption of cerebrospinal fluid. That is called communicating hydrocephalus. So what happens is that the entire system is expanded in the communicating hydrocephalus because there is that increased production of CSF. But in non-communicating hydrocephalus, there is an obstruction somewhere. There's an obstruction somewhere. So in non-communicating hydrocephalus refers to due to enlargement of only a portion of the ventricle system, e.g. due to blockage of the third ventricle. So the third ventricle maybe is blocked. We know the third ventricle is connected to the lateral ventricle via the foramen of what's this Monroe. But let's assume that we broke the foramen that is after the third ventricle, which is called the foramen of aqueduct. So if you broke that, it means that you are going to have accumulation of CSF in the third ventricle. So that is known as non-communicating hydrocephalus because the CSF is not communicating. So it's called non-communicating because the CSF is not communicating. So when CSF increases, that we are going to have hydrocephalus. That is what it means when they say hydrocephalus. So very, very important. But if this happens in infants, infants is a newborn. So an infant, in fact, not an infant, you have got a neonate. A neonate is a newborn. It's a time between the time of birth to 28 days. And then from 28 days to somewhere 1 year plus, it's called an infant. So now because an infant is still as, the fontanelles that are not closed. So now if that CSF accumulates in there, there will be an enlargement of the skull. This isn't what you call it. Leading to the enlarged, that head that you see, the head that is enlarged. That is called hydrocephalus or congenital one. If it happens congenital, I mean that the baby will be born with that due to maybe those infections that we talked about, the torch infections. So this condition did not increase the volume of CSF within the cranial cavity. That is just what hydrocephalus is. It's just increased CSF, elevated CSF in the cranial cavity, in the cavities that we talked about. In infants, it is associated with what? Sometimes marked enlargement of the skull. Hydrocephalus is most often caused by obstruction to CSF, meaning that is obstructive hydrocephalus because it's not communicating. By mechanisms such as congenital malformations, inflammation, tumors. You can have tumors, inflammation. Or it can also occur due to overproduction of CSF by the great plexus. Maybe you have a tumor in the great plexus, called the papilloma, it will be producing a lot of CSF, and that is going to lead to what? To overproduction of CSF. So that is also a malformation. Oh, sorry, yeah, that is the one that is caused by overproduction or reduced absorption is called communicating, because CSF is communicating. It can also occur in hydrocephalus ex vacuo. So ex vacuo hydrocephalus, there is no obstruction or there was no increased production, but in disorders characterized by decreased cerebral mass, such as ischemic brain atrophy or advanced Alzheimer's disease. So when there are those disorders, you can have also increased CSF production in cerebral mass. By decreased cerebral mass, such as ischemic brain. So there is maybe reduced blood to the brain. So if there is reduced blood to the brain, what happens is that there will be reduced supply of oxygen and nutrients to the brain, and hence that is going to make like the body will sense that it is producing less CSF, and then it will start producing a lot of CSF. By that way, that is leading to increased CSF, also known as hydrocephalus. Your friend was asked this question on the word, what is hydrocephalus? The way they answered this question, guys, let's be serious. Let's make sure that we master them as now. So hydrocephalus occurs in these forms. We've talked about this internal hydrocephalus. There's increased volume of CSF entirely within the ventricles, just within the ventricles. Then we've got external hydrocephalus. The increased volume of CSF is confined to the subarachnoid space, meaning that it's even moving from the ventricles, also going outside. But the main or the major classification that we have to remember is the non-communicating and the communicating one. So now remember, we said if the CSF was increased to the amount that is not supposed to be, you're going to have what we call let me just cut this video so that at least we can have another one recorded. Or let's just continue, we finish up with this. So remember what I said, if you have increased CSF in the brain, in the skull, what happens is that you're going to have increased intracranial pressure. That can lead to herniation, because CSF is going to move. If you go back to the Monroe-Care hypothesis, CSF will move blood, and then at the end of the day, the brain itself can herniate, leading to the types of herniation that we talked about: subfalcine or falcine herniation. Talked about transtentorial herniation. We talked about tonsillar herniation and how they present. So it's just important to remember that as well. So I've talked about anodicular malformation. This is a downward displacement of the cerebral tonsils, the medulla, and even the medulla oblongata through the foramen magnum. At least these ones are not classifying them in the two types, but as we classify them in the two types, in short, what are we supposed to know is that there is displacement of the cerebral tonsils, meaning the cerebellar same tonsils, not cerebral. Cerebellar tonsils and the medulla through the foramen magnum. They are displaced down. They're not supposed to pass through the foramen magnum, but they are displaced inside. So anodicular malformation results in pressure atrophy of displaced brain tissue. Now imagine this is the cerebellum and the medulla oblongata that has been herniated through the foramen magnum, meaning the foramen magnum can coalesce on them, leading to ischemia, and that can lead to the atrophy of the same structure that have been displaced. In addition, it causes hydrocephalus as a result of obstruction of CSF outflow. Remember, it's passing through the foramen magnum. And if you remember very well, is it the foramen, the aqueduct foramen? I don't know. Should be the foramen, the aqueduct of sorry, the cerebral, the Monroe. What's this? Is it the Monroe? No. It's supposed to be the cerebral aqueduct. It's supposed to be in the brainstem. So that specifically the medulla oblongata. Is it the midbrain? In the midbrain. So now there is that herniation. So if there is that herniation, meaning that it will compress on that foramen, and hence CSF will be blocked from coming out. That is going to lead to obstructive hydrocephalus, which is also not obstructive, but non-communicating hydrocephalus. Presence of thoracolumbar meningomyelin is almost always characteristic, meaning that if you see the patient or the baby that is born with the thoracolumbar meningomyelin, we've talked about meningomyelin. We said meningomyelin is just the congenital malformation, which is characterized by the presence of the meninges outside with the spinal cord. They are just outside. So if you suspect the baby or the fetus to have that, it means that there are high chances that the baby it's having they are not the QR malformation. Or you can have agenesis of corpus callosum. Now, remember what I told you, the corpus callosum is a commissure fiber, meaning that it connects the two hemispheres, the right one and the left one. For those that were not there, you can just watch that video for you to understand what the corpus callosum is. The video for the cortex, those notes for Dr. Mtari. So the corpus callosum is the commissure fiber. It's an example of a commissure fiber which connects the two hemispheres, the right one and the left one, so that they can communicate and do things properly. So now, when there's agenesis, meaning that there's underdevelopment or there's no development of the corpus callosum, that can lead to us abnormalities. It can be asymptomatic, but it can be associated with other symptoms. How about fetal alcohol syndrome? So this is associated with excessive maternal alcohol intake during pregnancy. It is characterized by facial abnormalities, developmental defects such as microencephaly. The baby will be born with a small brain. Arterial septal defect. This one is very important for cardiovascular. Arterial septal defect. There's an MCQ that they bring. So arterial septal defect is due to fetal alcohol syndrome. Even the same neotube defect that we've talked about are caused by the same fetal alcohol syndrome that is caused by excessive maternal intake of alcohol, etc., etc. So that is important to remember. There can be also growth retardation because of alcohol that the mother was taking. So that is going to affect the fetus who is inside her womb, her uterus. Tuberculosis syndrome. Tuberous sclerosis syndrome. This is not important. They cannot ask you this. So I'm not going to talk about it. So cerebral vascular disease, meaning that we are talking about the conditions, or maybe let's just cut this video so that we start another one for the last one.